Another glorious day outside. It really is lovely. So hopefully you've all been out, or if you haven't been, you'll get a chance to go out, because it is gorgeous. Okay, so my job today is to talk about calcium disorders and some of the drugs that you will use to treat them. But first I'm going to ask if there are any questions anybody wants to ask from the last lecture. Okay, well then we will get started, because we have to get done early so you can take a long break and go outside. Okay, so again, this is going to follow a similar path that I usually take with these lectures. We're going to talk a little bit about physiology to kind of focus your mind in on what we're going to think about with calcium metabolism. We're going to talk about hyper and hypocalcemic disorders, and then we're going to talk about some of the drugs that you're going to use. Not as common as some of the other things that we've been talking about, but again, some important concepts to understand. All right, so let's talk a little bit about the physiology of calcium regulation. So there's some major players that you need to know about. Parathyroid hormone is one, vitamin D is one, calcitonin is one, mainly because we use that hormone to help us, not really because it's that important in our day-to-day regulation of calcium. And then PTHrP, which is parathyroid hormone-related protein, is another one. That is made by cancer cells. And the only reason I'm telling you about it is because we use it diagnostically to help us. The major organs involved in calcium metabolism are the intestine, the bone, and the kidney. So we're going to start with vitamin D, okay? Vitamin D increases plasma calcium and phosphorus. I can't even talk this morning. You know, this is what happens when I woke up and wasn't it wonderful last night? I slept with my windows open, and so it was nice and cool in the bedroom, and I usually get up at 5 and I run or something, and it was so nice and cool out, and my husband was there, so I rolled over and I like cuddled up next to him, and then I woke up and it was like 6. So I had to get my day started with no coffee, and that does not go well for me. So I may not be able to speak that well this morning. So if I stumble, it's because I haven't been fully caffeinated. And then everyone talks about all the drugs that you need to take, and I'm thinking to myself, God, caffeine, like what would we do without it? Okay, so vitamin D increases your plasma calcium and phosphorus concentration, and the main place that is going to work is on the intestine. Important to remember, because when we talk about our hypocalcemic disorders, which you'll see sometimes, you won't see them a ton, you'll see them sometimes, we're going to be talking about the mainstay of therapy, which is really vitamin D, because you really need that to help you absorb calcium from your intestinal tract. This is why in milk they have like vitamin D supplemented in milk, because again it helps you absorb the calcium that you need. So it works mainly on the intestines to help you absorb calcium and also absorb phosphorus. It also works on the kidney. It promotes reabsorption and calcium and phosphorus. Reabsorption of calcium and phosphorus from the kidney. So it's going to help bring that in. And just so that you know that you're very apt to keep your calcium in your body, so 98% of it is reabsorbed. Okay, so vitamin D, to remember, it's the day-to-day control of your serum calcium. And for this class in pharmacology and not physiology, it's just, I'm telling you about this so that when we talk about how we're going to use vitamin D to help us, it makes sense why you use it the way that you do. So, the minute-to-minute control of calcium is pretty much maintained by parathyroid hormone. So, calcium, I think all of us will agree, is a really important cofactor for many, many enzymes, and you want to make sure that you have a pretty consistent level in your bloodstream of it. So the parathyroid hormone is going to be really important with that. So it's going to work, it's synthesized by the chief cells of the parathyroid gland. We talked about where that was. We talked about how it's near the thyroid and why when you do a thyroidectomy in a hyperthyroid cat, you want to make sure that you don't take both thyroids out at the same time, because you can affect either the parathyroid glands or the blood flow to them, and that will make you hypocalcemic because you need that parathyroid hormone to maintain your day-to-day calcium concentration. So vitamin D causes basically an increase in calcium and an increase in phosphorus. Parathyroid hormone is going to work a little bit differently. It's going to work quicker, and it's going to cause an increase in plasma calcium, but the overall effect is going to be a decrease in plasma phosphorus. So it works on the bone, and it increases bone reabsorption and calcium mobilization. It also works in the kidney, and it decreases your reabsorption of phosphorus. And so you get rid of your phosphorus, but it also works to reabsorb your calcium. Okay, so again, that's all that, I'm just giving you a little bit of basis to kind of understand how we're going to work with the drugs that we end up using to treat parathyroid hormone disorders and also disorders of excess or low calcium. The other hormone I'm going to talk about is calcitonin, not because it's that important in an adult animal, but because we can use it to help us pharmacologically. It's synthesized by the parafollicular cells or the C cells in the thyroid gland, so not a major player in an adult animal in your day-to-day regulation very much. It's very small peptide. It lowers circulating calcium really, really quickly, and that's how we'll use it pharmacologically. It inhibits bone reabsorption. It works very quickly on the osteoclast as well. In the kidney, it also increases calcium excretion. So again, works really, really quickly. Okay, So those are our three main hormones that we're going to use to either monitor or to help us fix calcium disorders. So we have vitamin D, that's going to help you reabsorb calcium in your intestine. We have parathyroid hormone, which is really responsible for your day-to-day calcium regulation, and it's going to cause an increase in calcium. You're mostly going to pull it from the bone. Also important because it causes a decrease in phosphorus through the kidney. And then calcitonin, which we're just going to use to help us pharmacologically, which can drop your calcium, okay? Now we're just going to talk about some of the diseases that you're going to see, mainly to give you a focus as to why you may use these drugs that are going to affect calcium. So there's some disorders resulting in hypercalcemia that we see. What's the most common, do you think? Cancer, cancer, and cancer. So whatever I tell you about endocrine systems, it is not the most common reason to see hypercalcemia. Do we see hyperparathyroidism? Absolutely we do. Is it common? No. What is the most common cause of hypercalcemia? Is cancer. All right. I don't work well with mnemonics at all. I never use them except for this one. And this one will be forever ingrained in my mind because my first day of clinics when I was a senior student, somebody asked me what the differentials for hypercalcemia were, and of course I stood there like, you know. So even if I ever knew it, there's no way I was going to remember it at that point. And that's when this person taught me the mnemonic for hypercalcemia. So you will hear this. Were you guys already acquainted with this in physiology? Did Dr. Bugby talk to you about this? Well, somebody will at some point when you learn about hypercalcemia, but this is just a nice mnemonic to remind you about things that cause hypercalcemia. Again, when you get into clinics, it's a helpful thing to remember so that, because I'm sure this will come up. There are a bunch of different ways you can do it. I use the gosh darn it, but there's some other stuff too. But anyway, these are all your differentials for hypercalcemia. All right. Clinical signs of hypercalcemia, and I will say, I'm sorry, the most common is cancer, which is under N for neoplasia. Look, I changed my thing. Look, now it's red. It's this red dot. It's very exciting. What's the most common cause of cancer that we see in, especially dogs that get hypercalcemic, and cats actually? What's the most common cancer that causes hypercalcemia? Lymphoma. So when you see a hypercalcemic animal, especially a small animal, your top 5 differentials are lymphoma, 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 and lymphoma. And then we go on to everything else. I hate to say that as an endocrinologist, but I have to tell you that is the truth. Okay, so what are some of the clinical signs of hypercalcemia? So we know that calcium ions can be really toxic when they're really, really high. And there's a lot of things that calcium do. They're cofactors for almost every type of enzyme that you use. If you have a lot of transport systems, the two most common ways you're going to get stuff in and out of the cells is to use a sodium transporter type system and also a calcium transporter type system. The other thing that calcium is really involved with is exocytotic activity. So like for instance, if you want to excrete things by exocytosis, you're going to be using a lot of calcium. So I don't think I have to convince you that they're really, really important. Some of the particular organs that are very affected by hypercalcemia are the CNS, the GI. The GI thing isn't, we don't really see that much clinically, but CNS, heart, and kidney. And I'm telling you this because as a doctor, you have to make a decision as to whether or not you're actually going to treat hypercalcemia. And the decision that you make is going to be based on whether or not there is injury to any of those organs. Okay, so what are some of the clinical signs that will help you identify whether hypercalcemia is a problem? The big one's going to be polyuria and polydipsia. Cats and dogs in particular are very sensitive to hypercalcemia, and they will start drinking a ton of water if they see it. So that is a really common presenting complaint for hypercalcemia, is polyuria and polydipsia. Hypercalcemia interferes with ADH at the level of the collecting duct. Remember, that's the part of the kidney where you're able to reabsorb or excrete just straight water. So it's very, very potent in terms of activating your, or regulating your hydration status, because you don't need sodium or anything else. It's really just water. Aquaporins go into the membrane. It's a very potent way to regulate your hydration. So it interferes with ADH at the collecting duct level, and so that's why it's so profound in causing polyuria and then a compensatory polydipsia. Hypercalcemia, again, one of the organs that calcium ions specifically affect are the kidney cells, and so it's directly nephrotoxic. And again, that's going to be one of the big signs that you're going to use to tell you whether or not you need to clinically treat hypercalcemia or not. Long-term hypercalcemia can cause calcium uroliths. That's a big pain in the butt because you have to go in and take them out because we don't have good diets to dissolve them. So if it is one of the reasons why also long-term hypercalcemia is something you're going to need to deal with, because again, calcium oxalate uroliths can be a big problem in terms of you being able to remove them. Okay. Yeah.
On the previous thing, if it affects like the collecting duct and you were saying you just lose water, will we see dehydration a lot in these, or does polydipsia like make up for it?
Yeah, that's a great question. So the really cool thing about water balance in animals is they don't really have a mind like we do where we say we should drink or we should not drink. They just do it. So as long as they're able to drink and they're not vomiting or anything like that, they should be able to maintain their hydration status. But one of the big problems that happens with these guys is if they don't have access to water, or if they don't, if they have GI problems and they're vomiting or whatever have you, they absolutely can get dehydrated pretty quickly. This is actually one of the things that causes an Addisonian. It's a different mechanism, but again, with an Addisonian, if they're able to drink, they'll compensate for their water loss. But if they're not able to drink for whatever reason, then they can get dehydrated pretty quickly. Okay, so what do you see when you're hypercalcemic? And basically, a lot of the clinical signs of electrolyte abnormalities, it's very hard for you as a clinician when you're seeing the case coming in to tell what's going on. Like, you're not going to look at something and say, oh, that's a calcium abnormality. You're going to look at that animal if it's twitching or if it's really weak or you have some sort of gut stasis. You're going to say, you know what, that's probably an electrolyte abnormality of some sort. And the first thing you're going to do is run something so that you can look to see what electrolyte is abnormal. So I'm going to tell you what this looks like or some of the things that you might see, but it's not going to differentiate this a cause of hypocalcemia is pretty, anyway, you're not going to be able to tell really. So you're going to be running tests to determine it, but calcium can do a whole bunch of different things. So if you have hypercalcemia, you're gonna, you can have muscle weakness and atrophy. Remember that you're looking for an action potential, and if you have a lot of positive ions, if you're really hypercalcemic, that's gonna decrease it. So sometimes you can cause excitability, but most of the time what we see is just muscle atrophy and muscle weakness. But again, that's not gonna be something you're gonna look at and say, oh, that animal's hypercalcemic. You can see depression and coma, anorexia, vomiting, and constipation because you have gut stasis from hypercalcemia. You can see bone pain and pathologic fractures. And that's going to be something where you have a hormone like hyperparathyroidism, where it's pulling stuff out of your bone, or cancer, either in the bone, or cancer like lymphoma that's then causing osteoclast activity. So something that's working on the bone would do that. Not very common unless you have bone cancer. Other things that you'll see, because cancer is the most common differential for hypercalcemia, you are going to see primary signs of cancer. So for instance, lymphoma, I told you, is the most common cancer causing hypercalcemia for sure. and it's the most common reason for hypercalcemia that we see. And so you'll see signs associated with that. So for instance, if it's gone into the bone marrow, you might see anemia. You might see big lymph nodes if it's in the lymph nodes. So depending on where it is, you may see signs that are associated with that. You can see a bunch of cardiac arrhythmias, and I do remember, so what is reported in books is that you see a prolonged PR and a shortened QT interval, but I asked, when I was taking the little quiz that you have to take to become an internist that goes on for 2 days and it's really horrible, I asked the cardiologist at the time, what do I see, what do you really see with hypercalcemia? And he said anything, because when you're supplementing calcium to a hypocalcemic animal, you're probably going to want to put an ECG on if you have one available, or at least monitor your heart rate. And I said, because I figured that's going to be a question on this exam, right? Like, what am I going to see first? And he said you could pretty much see anything, but this is basically what the textbooks say. Not that you probably won't ever get, I won't ask you that. And you may get asked that on your NAVLE or something later on, but anyway, this is what it says. Okay, so why are we going to treat these guys? So really, do you care if they're hyper? What if it's a dog and it's got plenty of access to water, it is really PUPD, but it actually looks pretty normal, and most of these guys, when they come in and they're hypercalcemic, they look pretty good. If they've been able to compensate by their drinking, you're not going to see a lot of clinical signs. So why are you going to worry about it? Well, you're going to worry about kidneys. So if you have an animal that's already got chronic kidney disease of some sort, you're going to jump on hypercalcemia and treat it right away. If they're dehydrated, you're going to be worried about that, because dehydration always makes everything worse. And certainly in the case of hypercalcemia, it's going to make your electrolyte abnormalities even worse. You're going to worry about it if you have an animal that's got heart disease, if you've got an animal that's either showing CNS signs or has underlying CNS disease, or if the animal's got calcium-containing uroliths. These are all going to be things that you're going to jump on in terms of treating the hypercalcemia. Okay, so let's talk a little bit about what you were going to do if you are in the emergency room and somebody brings in an animal that is very hypercalcemic, and let's say it's a dog that's you're suspecting has lymphoma, it's very hypercalcemic, very PUPD, and it's also got CKD, so it's got chronic kidney disease. Let's say it's stage 2, and you're thinking to yourself, okay, like, I'm worried about this. I got to do something about this because I don't want the kidney disease to get worse. All right. So the first thing you're going to do is give fluids. Fluids is usually never a bad choice unless they're in heart failure. One of the things that made me relax about being a veterinarian when I was going through school was the fact that I realized if I could probably just get an IV catheter in and get them on fluids, I could save most of the animals while I tried to figure out what was actually going on. Like, as long as you get going with fluids, usually you're okay, except if they're in heart failure. But certainly for hypercalcemic animals, IV fluids help you. We like to use sodium because you overwhelm the sodium and you overwhelm. And as you know, in most of the renal reabsorption, things tend to follow sodium. So what will happen over time, if you flood the system with sodium, sodium will be reabsorbed more than the calcium. So IV fluids help you. Anything you have will help you, but saline is nice because there's no calcium in it and you're giving them a flood of sodium. Okay, furosemide helps you, okay? So it works in the ascending loop of Henle, as you probably remember. Do you guys get, oh, this one doesn't, oh yeah, it does. Does it have it in here? Yeah, here it is, it's right here. This is a great, I copied this from somebody, but when you guys go through studying, I'm sure somebody's gonna go through diuretics for you in this class, and you'll be seeing this periodically. These are nice little cartoons to have to remind you where all the diuretics work, just so you know where they work. Anyway, furosemide is one of the most potent diuretics, and it works on the ascending loop of Henle. And it mostly works by blocking sodium uptake, but also calcium uptake as well. So that is very potent. You can use glucocorticoids. And we talked about some of the things that glucocorticoids do. One of the things is they promote calciuresis. So that's also going to help if you're hypercalcemic, because it's going to decrease the calcium that you have. The caveat to this is you're only going to want to use them if you've ruled out lymphoma. So why is that? What do glucocorticoids do to lymphoma cells? They kill them, right? They're lymphotoxic, right? So they'll kill lymphoma cells. And what happens if the owners say, okay, I am never going to do, if this animal has cancer, too bad, I'm not doing anything about it. Feel free to use glucocorticoids to help with your hypercalcemic animal. Unfortunately, what happens with some of these guys, they'll come in hypercalcemic, they get glucocorticoids, and then they get referred to the University of Georgia for a workup. And we say, God, I know this animal's got lymphoma, but I need to prove it before we can actually treat it. So you go on a cancer hunt, right? And I'm looking all over the place for the cancer cells, and I can't find them because the glucocorticoids have killed them. So, and you have to wait for them to come back before you can actually diagnose the disease. The other problem is, let's say I'm lucky enough to diagnose it, so I find them in the bone marrow, and they go for chemotherapy. Well, you've already given this animal glucocorticoids, and that's going to induce the transport systems that actually kick out, that the neoplastic cells develop, that actually kick out the toxic drugs, and so the chemotherapy that you use will be less effective. So I'm telling you this also as referral practitioners in the future, please don't give somebody a shot at glucocorticoids and send them in for referral, because if you do that, it messes up sometimes the chance to treat them, but also diagnostically as well. But anyway, if the owners say, I don't care why this animal's hypercalcemic, or you know it's hyperparathyroid and you're not going to do anything about it, feel free to use glucocorticoids. That can help you. Okay, we can also use calcitonin. This is something that you would use. You give it intravenously, and it's a short-term fix. It's not a long-term fix. So this is something that you would use if the animal comes in is very hypercalcemic on an emergency basis. It is really good at dropping the calcium really, really quickly. It totally inhibits osteoclast very, very quickly, and so it'll help keep all the calcium in the bone. There are a couple of problems with it. One is, in some animals, it doesn't work. I've had good luck with it in my hands, but we recently tried it, and it didn't seem to work very well. So it doesn't work in all animals, but the big problem to it is they get refractory to it after about 48 hours. But if you have an animal in an emergency situation, you need to get the calcium down. Let's say it's got arrhythmias, or it's very comatose, and the calcium is sky high, and you need to get it down. This would be a good drug to pick. Okay, long-term treatment for hypercalcemia, bisphosphonates can be your friend. These are long-term osteoporosis drugs that are used in humans. We've used them successfully in animals that are hypercalcemic. If they're hypercalcemic because of cancer, you'd want to treat the cancer, and that'll probably take care of the problem. But if they're hypercalcemic because cats will get an idiopathic hypercalcemia, and you have no idea why, and you just treat the hypercalcemia. Dogs may be hyperparathyroid, and this is a great example. So the dog has hyperparathyroidism, and it's like 1,000 years old, and it's got chronic kidney disease, and you're like, I'm not doing surgery on this dog. I just want to keep the calcium at a reasonable level. This would be a drug to think about using, just to keep the calcium so that you don't cause any further kidney damage. So there's a bunch of them out there. The one that we tend to use most is alendronate or Fosamax. It's an oral drug used commonly to treat hypercalcemia in dogs, but also like idiopathic hypercalcemia in cats. The caveats to using it are that it can be cause an esophagitis. So it can irritate the esophagus. You can get a stricture if it's really, really bad. So you want to make sure that you give the animal a lot of water and make sure they get the pill down. What some people do with cats is like coat it in something slippery so they eat it and it goes down. So that's one caveat with using that long term, but it does work really well long term to treat hypercalcemia. And I think long term you give it to them like once a week. With the other drug that we use a lot is pamidronate, and that is given parenterally. It's given intravenously once a month. You can use that for hypercalcemia treatment, that's fine. But one of the ways that's really helped us as doctors is it treats bone pain in dogs that have like osteosarcomas, and we're treating that. They get very, very painful where that tumor is, and the pimidronate is really helpful in treating that. But you can also use it like intravenously once a month to treat hypercalcemia as well. Okay, so bisphosphonates, they're very potent in inhibiting osteoclast activity, and they actually promote apoptosis, which is why you can give them like every month, because the effect of them lasts a long time. And they're very, very potent. Okay. Oh, I put more in here than I thought I did. Here we go. Alendronate Fosamax orally, pimidronate injectably, and again, palliative for bone tumors. Where's the bone tumor on this radiograph? It's right here. Okay, if you had to guess, what would you say that is? You'd say an osteosarcoma, that's what I would have said. But guess what it is? It actually was a multiple myeloma, which can actually go into the marrow cavities. It's a round cell tumor. It can go in the marrow cavities. So this was actually, this picture is so old, but this was actually a, yeah, it was a dog. It was a dog that had multiple myeloma. Okay, any questions on those drugs? Yeah.
So what part of lymphoma causes calcium levels to go high?
Yeah, that's a great question. So lymphoma cells secrete parathyroid hormone-related protein. So it's a protein that looks like parathyroid hormone. It's actually been cloned from lymphoma cells. We know that canine lymphoma cells make it. And so it's released from those cells. It looks like parathyroid hormone and acts like parathyroid hormone. It is, again, it's just produced by neoplastic cells. But the reason that I mentioned it, and the reason I want you to know about it, is you can actually measure it. So we'll send out they call it, what do they call it? Like my name for it's the cancer panel, but there's a different name. But you can send it out to IDEX, and they will measure ionized calcium. They'll measure vitamin D, but they can only measure D2. They can't measure D3, and they'll measure PTHRP and PTH levels as well. And that will, if the PTHRP is positive, you know you have cancer, and it can be anything. It's also been found with all kinds of carcinomas. So it's kind of a cancer protein that you look for. If you don't see it, it doesn't rule cancer out, but if you do see it, that's why. The other thing that happens, like in multiple myeloma, is the round cell tumors actually get in the marrow and they actually eat away at the bone. So it's actually bone destruction that causes it for that one. Any other questions? Okay, so now we're going to turn the tables a little bit and talk about disorders resulting in hypocalcemia. So the big one that you think about as an endocrinologist, even though again this is not all that common, is primary hypoparathyroidism. We do see it periodically for sure, but it's not a very common disease that we see. What we think happens with primary hypoparathyroidism is that there's again, the usual mechanisms that we think about is there's immune-mediated destruction of these parathyroid glands. Either that, or you got very vigorous when you did surgery and you removed them along with the thyroid glands when you did a parathyroidectomy, or thyroidectomy. And so if you got really vigorous with that, then you might take out the parathyroid glands as well. But usually what we see in naturally occurring disease is, again, an immune-mediated attack on those glands. So what happens with that is basically you don't have any parathyroid hormone, you can't reabsorb calcium from the kidney, and basically the calcium you can't get it out of the bone, and so basically you block that whole pathway and you get very, very hypocalcemic. Okay, that's not the most common cause for hypocalcemia. What we see more commonly is eclampsia, and you tend to see that with dogs that have huge litters of puppies. You can see this is with milk fever in cows, and you can see it in foals with idiopathic hypocalcemia. We also see it with pancreatitis, but it's usually not that severe that you need to treat it. It's kind of subclinically bad. You can see it with intestinal malabsorption. Yorkshire Terriers get a really horrible form of lymphangiectasia, and they will become clinically hypocalcemic because of that you actually do have to treat. So we see that, and I think the big thing involved in that is really they just don't have enough vitamin D to help absorb the calcium. And then in cats, they used to use fleet enemas, which are phosphate-containing enemas in cats when they got constipated, and then they found out that they got very hypocalcemic because if you give them a big phosphorus load and they would actually absorb that, then the calcium precipitates out with the phosphorus because of the mass law effect. So you could see hypocalcemia from that as well. All right, so what do you see when the animals are hypocalcemic? Again, I think eclampsia, like milk fever, I think you would recognize. I remember that from when it was very common to see that. It was pretty recognizable. If a dog comes in who's eclampsic, you're going to recognize that after you see the first one. I don't have a lot of experience with foals, but I would imagine it's pretty straightforward. You would recognize and think, oh, they're probably hypocalcemic because they're going to be down and flaccid, and they're probably going to look pretty bad. In other situations, it may be hard to pick up what it is. Again, a lot of times what you're going to be doing is saying, oh, there's probably some kind of an electrolyte abnormality, and you will end up measuring it and finding out what it is. You can see muscle twitching, cramps, tremors, or tetany, and again, that's something you can also see with sodium and potassium abnormalities, so you're going to be looking at your electrolytes. You can see restless dementia or seizures, ataxia, staggering, or weakness. The one thing that is something that you'll see that'll kick you off to it is licking. For whatever reason, when dogs, and dogs especially, when they get really hypocalcemic, they lick their feet. They also rub their face. We just had a little dog in, I guess, gosh, it was probably like 6 months ago, who was hypocalcemic, and we could tell when he got hypocalcemic because he'd start rubbing his face all over everything. So that's really common for whatever reason. And you see that in cats too. They tend to rub their face. And then hypothermia. All right, so what are our treatment objectives? This is the same thing that we always talk about. If you don't make enough of something, what are you gonna do? Supplement it. So you're just gonna like pour a ton of calcium in them? Well, probably in a cow you can do that, right? I think I remember standing out there with these big bottles that you held up. In littler animals, and probably in foals, you have to do it a little carefully because what can happen? You can make them hypercalcemic. Is that good or bad? That's bad. What happens? Yeah, you have horrible heart arrhythmias, and then you go into stuff like asystole, and that doesn't go well. So, so anyway, you have to be a little bit careful. But treatment objectives are we supplement, okay? So you can treat the acute hypocalcemic patient. We usually use 10% calcium gluconate, and you can, there are formulas to figure this out in every emergency textbook out there. I will tell you, I'm a frickin' weenie, so whatever the dose is, I give a fourth of it, make sure they're okay, then give another fourth, make sure they're okay, and you just want to make sure that you monitor them somehow with some sort of a way to look at their heart rate, whether you're measuring it and you're feeling it, or even better if you have an ECG, you can put the ECG on. The other thing I will tell you is that magnesium is a really important cofactor for parathyroid hormone synthesis, and if they're hypomagnesemic, you will never get the calcium up. And this happens, I actually learned this before it was published, because we had a run of cases. Everything always comes in threes, it seems like, and it's like you'll see some you haven't seen in like 3 years, and all of a sudden then you see 3 of them. But I remember there were a whole bunch of hyperosmolar diabetic cats we saw, like 3 in a row, and all of them were hypocalcemic and all of them were hypomagnesemic. And we had just started measuring ionized magnesium, which is pretty standard to measure now. And I remember thinking at the time, well, I'll just fix that. And as soon as I did, the calcium came up. And then I read about it and found out that it's a cofactor for parathyroid hormone synthesis. So I'm just warning you about that. If you have a hard time getting calcium up, make sure their magnesium's normal. We usually ignore magnesium because we don't know what it means, except for this. Okay, the mainstay for so acute treatment, you're going to give them calcium, right? Mainstay treatment, what you're going to do over time with these guys is the mainstay of treatment is going to be vitamin D. And for the most part, you're going to use vitamin D3 therapy, okay? That's calcitriol. That's the active form that's actually made in the kidney, so they don't have to resynthesize it. You can get vitamin D1 and vitamin D2, but they have to be synthesized by the kidney and really not very commonly used. So we use calcitriol. The onset of action is pretty quick. You don't have to convert it to the active form, and it goes away, 2 weeks theoretically. That is not what I've seen. It usually goes away in a day or two if you remove it. So it's a little expensive, but it's not prohibitive. So do you need calcium supplementation long term? The answer to that is no. We usually put them on it to get them through the acute phase, and then you can pull them off the calcium, and then you can maintain them on vitamin D long term. And that would be for a permanent hypoparathyroid animal. Otherwise, if they've got like tetany, or they've got like with the fold diseases, or they've got some other hypocalcemic type disease, like if they're hyperosmolar or something like that, you're going to fix that, and that's going to take care of the calcium. But if you have a hypoparathyroid animal that's truly long-term hypocalcemic, then you're just going to treat them chronically with vitamin D3, and then put them on a good diet, and you don't have to calcium supplement them long-term. Yes?
This is a really dumb question. I'm gonna
Probably
ask
not.
When we saw like people would come in with their eclectic dogs and then they could only afford the exam, we would always tell them like go home and get Tums because you
Yeah.
probably already have that. Is it possible for you to overdo it with Tums, like if they just gave the whole bottle? Is that
Yes. So the question is, can you overdo Tums therapy? You absolutely can. It's pretty hard if they don't have enough vitamin D, but as long as they're making enough vitamin D and they just have eclampsia, you can overdo it with the Tums. But I think, in my experience, because I've done the same thing, I've told them to go home and take a bunch of Tums. I've never done that acutely. They have to do it like, if they do it like for 2 weeks or something, they overdo it.
Yeah.
But they can cause stones too, because then they just start peeing it all out. But yes, you can overdo it with Tums. And certainly with these guys that are hypoparathyroid and you're treating them long term with vitamin D, if you keep supplementing the calcium, they'll get hypocalcemic. There was another question. No? Okay. Good diet, then you can take away the calcium supplementation and start them on vitamin D therapy. It takes a couple of days to kick in, and then you can gradually wean their calcium supplementation. All right. I was going to introduce you to Duke as a case, but any questions before we do that? Okay, this is Duke. Duke is an 8-year-old male intact Labrador Retriever who presented for collapse to us. He was last normal the day before presentation. The history is, I was really excited when this case came in because this is a hunting dog that collapsed. And it's a Labrador Retriever. He's a little bit old, but he's a Labrador Retriever, and he's a hunting dog that collapsed. That it probably doesn't spring anything to anybody's mind. It's only if you're a weird internist you think about things like, oh my God, maybe it's like oxidative stress on the red cells, which we can see like with the pyruvate kinase deficiency or something. Anyway, hunting dogs tend to get that, and I was really excited when I saw this on the list. And I thought, oh my God, it's going to be this. And you can decide whether you think it's this or not. So they took Duke hunting, and he collapsed when he got back to his kennel. He panted and turned blue. They took him to the veterinarian. He recovered slowly at the veterinarian. The veterinarian did check an ECG, which was normal. So they took him home, and he was fine after that. He ate and drank normally, but the next morning he vomited food and 2 corn cobs, okay? Corn cobs are the death to Labrador Retrievers because they're the right size to sit right in the pylorus. So, you know, you're always worried about the corn cobs. And he was weak and wobbly, and they brought him to us. And so the resident was all excited because she thought, oh my God, we get to scope a corn cob out of this dog. I was all excited because I thought, oh my God, it's a pyruvate kinase deficiency or PFK deficiency, and it's going to be a hunting dog anemia. And it turned blue. I'm so excited. Okay, so here's where the story unfolds. So he comes in, he's very agitated, licking his feet. He licked the floor, he licked the walls, he licked the exam table. And, you know, I mean, labs, I mean, they love to eat, right? You know, so you're like, okay, well, that's not that weird. And then it kind of got weird, and you're like, okay, that's kind of weird. His temp was 103, his heart rate was 160, and he was panting, so not too horrible. His mucous membranes were injected, meaning they're really red. It's a little hyperdynamic when you did his CRT, but slightly tacky. Auscultation was normal. His pulses were regular and synchronous with his heartbeat, but they were snappy. And that kind of goes along with him being injected in his membranes. His abdomen was guarded on deep palpation. And he weighed 33 kilograms. So our problem list for him was collapse, vomiting, panting, tacky membranes, snappy pulses, maybe a painful abdomen, and licking. All right. So his initial treatment, we put it in an IV catheter, and we got just a quick database on him. His PCV was 44%. Darn it. Although he could have regenerated by now. Who knows? I'm still hoping. Total cells were 6.7. He had an azostick, which was from 5 to 15. His dex was 105, so that's all normal. His pH was 7.5. But interestingly, look at his ionized calcium. It's 0.69. Normal is 1.25 to 1.45. That is really, really, really low. So I was like, oh darn. But he's hypocalcemic. That's kind of cool. Okay, so this could be fun. His blood pressure was 95, and that was a mean arterial pressure, so that's pretty good. ECG showed a normal rate and rhythm. We did do abdominal films on him because of the whole corn cob issue, and he did have a food and fluid-filled stomach from the radiographs, and this is a big dog. You just couldn't tell whether he was obstructed or not. Not a really scary obstructive pattern, but again, those corn cobs usually get stuck in the pylorus, so you would have a big fluid-filled stomach. So we bolused him with some fluids, and we gave him 10% calcium because he was so hypocalcemic. We repeated his ionized calcium. It went up to 0.77. We repeated the dose. Okay, and yeah, I'm a weenie because, like I told you, I always do like 1/4 of the dose. And he got another 10 mils of 10% calcium gluconate, put him on IV fluids at 150, 33, so probably just a little bit more than maintenance. So our updated list was collapse, vomiting with a possible foreign body, dehydration, licking, hypocalcemia, and alkalosis. So the next day we ran blood work on him, repeated ANOVA, and did a urine analysis and an abdominal ultrasound. His CBC was normal. His hematocrit was 41.9%, so that's fine. His white cells were normal with a normal diff. That's all fine. Phosphorus was 8.3, so that's high. His calcium was 6.0, so that's low. His sodium was 152, which I don't know if that's a big deal or not. And his ALT was slightly elevated, probably because he was dehydrated and hypoperfused, and the ALT likes to go up like that when that happens. Urine, specific gravity, this was, I can't remember if this was, yeah, we didn't know if it was pre or post fluids. We didn't know if it was a cysto or free catch, but his specific gravity was 1017 with a protein of +1. The nice thing is he's alkalotic and his pH was 8.5, so that means that he doesn't have any sort of renal tubular issues. Ionized calcium the next day was 0.86. We did ultrasound him. There was no obstruction, so that's good. He did have a functional ileus. So we continued his calcium gluconate as a CRI in his fluids, put him on Tums, calcitriol, Pepsid for his GI, and also some metronidazole to help with GI issues on him. And then we ran a PTH level on him. So his PTH is 1.4, and his ionized calcium was 0.97. So what do you think? He is hypoparathyroid. That's not even a guess. If your so first of all, his PTH level is low, but even if it was normal and he's really hypocalcemic, you would expect it to be high. It should be high at that point. So anyway, he's definitely hypoparathyroid. So 3 days later, his ionized calcium's coming up. We discontinued his calcium gluconate IV, kept him on his calcitriol and his Tums. And for maintenance, you don't have to keep their calcium perfectly normal because calcitriol is the expensive part of treating this. So you want to keep them so they're clinically fine. And he was pretty fine with a little bit of a lowish calcium. That would seem to be fine for him. And we kept him on a calcitriol level of, and it doesn't really matter, but it was 250 nanograms twice a day. All right, so that's what I had for you today. And I even finished like a little bit early, 1 minute early. But if there's any questions, I'm delighted to answer them. I will be back on Monday. So if there's anything that you think about over the weekend that you'd like to know that I can answer for you, I'm happy to. All right, so I will see you guys on Monday. Thanks. Yes, ma'am.
I understand how the hypocalcemia caused the collapse. Why did it cause the sinuses?
Oh, you know, that's a great question. I really don't know. I think it might have just been perfusion issues. And, you know, that's supported by the ALT being up in the liver. But I don't know. I'm not sure what. There's not a direct mechanism that I know about why it would cause that. But I was so excited because I thought it was something more interesting. And it wasn't. Oh, well.
Thanks.
I have two questions.
Yes, ma'am.
One, the GI stuff, do you think that was related to the corn cob, or do you think that that was,
Yeah.
like, that was
I
kind of a red herring situation?
Oh, I forgot to. Oh, I didn't even turn that on.
Oh, you were pretty loud, don't
Good.
worry.
I usually am pretty loud, but they get mad because I used to film all these and then they said
Yeah,
they couldn't hear
the
me.
microphone's supposed to, you're fine.
Good.
Question number two, is that pretty, like, normal presentation to be that acute with it? Like, he wasn't, was he
Yeah,
really?
that was really uncommon.
Okay.
I think what happened was, first of all, he was too old
Yeah.
to have it. And second of all, it was a weird presentation. The owners swear to God he was normal. And that was weird.
Yeah.
And I think the reason why it happened was because he got himself dehydrated with the whole corn cob thing and the
it's like
vomiting
something
from
that came
that. And I
before
think he
it.
got alkalotic because of that as well. And that's what brought it on. But that was a weirdly, and this dog was active. Like he hunted.
Yeah.
And so he was out doing stuff and the owner said he was absolutely normal.
Right.
So it was a weird presentation. He's too old and it was too acute.
I would think that something like hypoparathyroid would, like, be some, like, chronic, like, it would
You do, and
kind
you
of,
start
like,
seeing.
he hasn't been right for a while.
Yeah, and people will say that. The only thing I can think of was, you know, if he like was licking his feet and stuff in the kennel and they didn't notice him. But I think they said no, and I think they were pretty attuned to him. So it was weird. That was a weird presentation.
This
Yeah.
thing's like eclampsia, obviously, is like, I don't know, she was fine, she had puppies, and like,
Right.
it's always the damn chihuahua that they didn't
I know,
was
with like
pregnant.
10 puppies.
16.
And then somebody's always like, oh yeah, we wanted to make money off the puppies, and you're like, yeah, how's that going for you?
Yeah.
Yeah.
Yeah, we had a few of those. I worked in Tucson, which is like very close to the border, so we
Oh,
had lots
yeah,
of people
of
coming
course
by, and
you
they're
did.
like, yeah, we can't even afford the exam, and the dog's like having a seizure, and you're like,
Go home and give Tums.
it's
Hey,
got big
it
old
works.
boobs. did
Yeah.
she just have puppies? I'm like, yeah. I'm like,
And they're gonna sell them. They're gonna
Right,
sell
yeah.
those puppies. Yeah.
yeah. Or the Shih Tzu with all natted and disgusting, and you're like,
Yeah. High on the gene pool. Good thing you bred that one.